All right, I'd like to welcome everyone and thank you for joining us for a discussion of culturally sensitive treatment for eating disorder professionals. This discussion is part of the Marginalized Voices project brought to you by the National Eating Disorder Association and Reasons Eating Disorder Center. I'm happy and really proud to be speaking with three activists who are leading the charge to change the landscape of eating disorder treatment, recovery, and public perception. We'll be exploring what we mean when we talk about culturally sensitive treatment, the broader relevance of the issue, and how eating disorder professionals can make a real difference on both a single client basis as well as on a systemic level. My name is Norman Kim, and I'm very excited to be leading today's discussion. I'm a psychologist and the national director for Reasons Eating Disorder Center and Center for Change, and I've been working with folks with eating disorders for about 17 plus years now. And especially in the last few years, have really been focused on issues of advocacy within the eating disorder realm. And am very excited for this presentation and for our panelists. I'd like to take a few moments then to have our panelists introduce themselves. So Pia, if you want to introduce yourself.
Hi, my name is Pia Guerrero. I am the founder of the website Adios Barbie, which started as a body image website. I started it basically because I realized in the late 1990s that the communities that I was working with and that I was in weren't being recognized as people who suffer from eating disorders. And so we've now developed to be more a body politics and identity website, and we focus on intersectional feminism and also eating disorders. For myself, I had an eating disorder episode when I was a lupus patient, and my kidneys were failing, and I began restricting my own food as a means of survival and coping. And at the time, and still now, no one has ever, within the medical field, ever even knew that you could be sick and have an eating disorder. So that's one of the other reasons why I'm committed to this topic.
Great. And Gloria.
So I run Nalgona Positivity Pride, which is a Chicana brown body positive project of mine that focuses on eating disorder awareness in communities of color and in decolonizing the body. We have a support group in Boyle Heights here in LA, which is specific to people of color. We also have an and we are very active on social media.
All right, and then Dagan.
Hi, my name is Dagan Vandemark. My pronouns are they and them. I am the Program and Policy Coordinator of TFED, Trans Folks Fighting Eating Disorders. TFED is a little over 2 years old. We create gender-affirmative support spaces for trans and gender-diverse folks. We train healthcare professionals, mostly in the eating disorders field, as to how to provide more intersectional, more gender-affirmative care. And yeah, we try to make our issues more visible, and we try to emphasize intersectionality in the field.
All right, and then also joining us is Lakeisha. Lakeisha, if you want to introduce yourself.
Hopefully you can hear me. Can you hear me?
Yeah.
Okay. I'm Lakeisha Lafayette. Well, I run a group on Facebook called I Am Not White and I Have an Eating Disorder. I ran it with Gloria, and now I just ran it by myself. I'm trying to think what else to say. I work as a peer support specialist in Riverside. So I do a lot of mental health advocacy and outreach and different things around the community. I'm very passionate about mental health, particularly eating disorders, because I deal with eating disorders myself for a while. I'm in recovery, and I just like to, raise awareness of conditions and eating disorders as well, and break the stigma that it's not just one type of person that has an eating disorder or a mental health condition.
All right, great. So thank you all so much for joining us in this conversation, this very important conversation. So let's start by talking about the broader idea of culturally sensitive treatment. This idea is incredibly important. It can also be very difficult. These issues go to the root of who we are, how we identify ourselves, and I'd like to start this conversation by underscoring the importance of taking a collaborative approach and having an open discussion that also employs very intentional language. So as a starting point, I want to discuss what culturally sensitive treatment is, beginning with the language that we use to describe it. The phrase culturally sensitive itself is intended to highlight the importance of accounting for individual as well as cultural differences and cultural considerations, but the term is also fraught with historical tension. Pia, maybe you could start off by sharing a little bit more about why those who have been marginalized within the eating disorder community might be wary of the term culturally sensitive treatment.
Well, as you said, it's language. It's important to be intentional, and there's a saying, "Our words create our world." And when we're talking about cultural sensitivity, it's sort of like the term marginalized or minorities. It implies that there's a dominant culture and that they have to be sensitive to the other. And so that's one reason why it's fraught with tension, because it actually isn't centering the issues of marginalized identities, especially within eating disorders. And already marginalized identities are othered in eating disorders and eating disorders health care. And so for me, a term that I would prefer is culturally centered, which would imply that not only are practitioners who are white, cis, traditionally women, middle and upper class women, that would start changing the field to include people who actually are from marginalized communities, who understand the culture completely and able to fully understand and treat people who aren't in the majority, or at least who aren't in what we think is the majority of people who have eating disorders.
All right, Gloria, what about the idea that much of the recent conversation about eating disorders has been to reinforce that these are biological brain-based diseases with a strong genetic component? Given the emphasis on the biological roots of eating disorders, how do you consider culture in treatment?
Well, eating disorders happen all across different populations, and in reality, mental illness is considered a product of a complex interaction of biological, psychological, social, and cultural factors. So, communities of color in the U.S. face social economic inequality, so that includes a greater exposure to racism, violence, discrimination, and poverty, all which do take a toll on a person's mental health. And living in poverty has the most measurable impact on rates of mental illness. So culture needs to be considered because people of color also experience eating disorders. And culture influences the way patients from a given culture express their symptoms, their style of coping, their family, their community support, and their willingness to seek treatment. And likewise, clinicians have their own culture, which can influence the way they diagnose and the way they give treatment and the service delivery. So eating disorder service providers need to care about culture because the goal is to serve people the best possible way to help them in their healing journey.
All right. I want to open it up to the other panelists as well to weigh in on this. Pia made a really good point of the sensitivity part of this term. There is that connotation of sort of either we need to tiptoe around it because people are too sensitive or something like that. The whole idea of political correctness, etc. So how can we increase, or what's the importance of increasing cultural competency especially for something like eating disorder treatment?
I think Well, I think for me, what I've noticed working in healthcare with marginalized communities is that the healthcare system and field in general has already created programs and campaigns that address different cultures. You can look at the diabetes. Diabetes is very advanced in being inclusive and centering the issues of different communities, Black community, folks in the Black community, and Latino community. And so I think we're not recreating the wheel here. We're just raising awareness, and that there's a lot of models out there that the eating disorder community and field can adopt and use.
Yeah, there's been this interesting, something interesting happens specifically for eating disorders, and especially, even in my time in the field, in medical care and in mental health in general, there's been a long-standing push for a lot of these issues. There's very little. I don't think you need to do a lot of convincing anymore that people of color, that people in the LGBT community, that all sorts of people suffer from any number of medical and and psychological diseases, but somehow eating disorders has been really lagging in that area. Why does anyone think that what is it about eating disorders that we still have to have this much more basic level of education that, for example, eating disorders affect everybody? Dagan or Lakeisha, I don't know if you have any thoughts about that.
Well, I think it's just I think it's one of the reasons why it's just so underfunded, under everything, is because the culture we live in right now. I mean, some people think, oh, I'll go on a diet, and then they kind of misconstrue what an eating disorder is, and then kind of becomes the norm to think, oh, well, they can just stop, or it's just about food. There's serious things going on because people can't really wrap their minds around the fact that, there's more at work here than just your typical diet or health conscious or whatever culture. And also the fact that, since there's a whole push with the whole obesity epidemic and whatnot, that, anything that's not that or opposite of that's like, oh, wait a minute, well, there's a problem with obesity, so you can have your eating disorder over here in a box. We'll fund that later, but right now we got to focus on X, Y, and Z. It's kind of hard because, if you look at the funding for other mental health conditions like schizophrenia or bipolar disorder, or even, like Pia mentioned, diabetes or things like that, there's a lot of more information, more funding, more knowledge about that. But when it comes to eating disorders, it's more taboo, and I think because it's one of those things that nobody really wants to talk about because it just seems out of the norm of what society sees as healthy or conscious about body and weight.
Dakin, what about you? You were kind enough to come to Reasons recently to do a training on many of these issues. Why do you think there is still this need for very basic education about who eating disorders affect?
Sure. I think I'm going to mirror what Lakeisha said, and that's funding priorities are a big factor, as opposed to other mental illnesses, which have more public funding behind them. Funding for eating disorders is very private, and treatment is very privatized, and the treatment industry is very for-profit. It's a capitalist enterprise, and therefore goes after the people with the most money, who are generally not marginalized. If we are truly to serve marginalized populations, we are going to need to overhaul our funding priorities, overhaul many things, but yeah, I think everyone covered everything else pretty well.
Yeah, I mean, I know certainly on the professional side, this. I think the notion about what the nature of an eating disorder is really feels like that's contributed a lot to this illness. If you still think that an eating disorder is just about wanting to look a certain way, then it makes a certain amount of sense, I suppose, to think that some groups then are protected in some way because maybe their beauty norms are different. But if eating disorders aren't just about how you look, but instead are about how you feel about yourself as a human being, then there's really no reason to think that it shouldn't affect anybody, because any of us, regardless of gender, sexual orientation, ethnicity, any of us can certainly be suffer from from that more basic sort of I don't feel like I'm good enough as a person, and it seems like it's still a strong need to educate people on this is not just an illness of wanting to look a certain way.
I think one of the reasons why I started Adios Barbie was I had noticed my students, because I was teaching Latino and Black students, they were dealing with everyday trauma. They were walking over, they were from very, very distressed communities, dealing with gangs approaching them to join every which, around every corner, seriously. And what I noticed is they were having some symptoms of being obsessed with weight and taking diet pills and dieting. And I had gone to a conference that was for young women of color, an empowerment conference, and I said I want to do a presentation on body image and eating. And they told me that's not an issue that affects our community. And yes, that was 10 years ago, but I think that that's still happening now, that within community there's so many other issues, racism, classism, police brutality, that even if someone does have an eating disorder, there isn't an awareness, or it's a lesser of many evils, and so it's not given the priority within community. And also, if you have people who are wealthier who notice their children are having major issues, they're more likely to have the resources and the education to understand that this is anorexia, bulimia, and that. And then the other issue is that binge eating disorders, for some reason, from what I've noticed, aren't included within the eating disorder umbrella, and those issues affect more people of color. And so there's also a disconnect within the eating disorder community that needs to happen. So not only education within eating disorder, community, but also within communities that are impacted by it as well.
Yeah. So let's talk about treatment then. So I think however much energy we all sort of feel like we need to put into educating professionals and the community at large and the public, then it comes down on some level to treatment, to getting people the help that they so desperately need. So I want to talk about the importance and the relevance of culturally sensitive or culturally competent treatment. Lakeisha, when a treatment provider is not aware of their patient's cultural considerations, how can that affect treatment?
Well, it could put really just a negative impact on them getting help, them getting recovery, because when you're taking cultural differences into consideration, you kind of put them in the same box as you would someone, well, quote unquote, the typical image that you may see or think, and you don't take a look at what's their sexual orientation, what's their race, what's their culture, what's their religion, what's their language that they speak. And there's a lot of barriers that go on, and it can make a barrier to getting proper treatment, because it could leave a sense of stigma. It could leave a sense of like, okay, nobody's understanding me, and what do I do? And you can be at a loss, and it just compounds the issue and the trauma of having an eating disorder, because you already don't particularly fit into what typical. Okay, I like if you're in a wealthy family or in a something other kind of family, it's like, okay, you're sick, okay, let's go put you in residential and you'll be fine. But not everybody has that. Not everybody has the resources or the socioeconomic status or the privilege to be able to do any of those things. And when you, like, for example, for myself, I went into one of a treatment program, and kind of like, deal with this because I have had patients use words, but this is new to me, and well, it's new to me too. I'm just getting help here. But it really impacts treatment in that it can negatively impact, the way it can negatively impact the way, people, the person that's suffering from ASOR and the person that's treating them to get the best level of care for that person. Um, and courses and with the way you talk to a patient or the way you talk to someone with an eating disorder is a little bit can be skewed by what you normally see, what you don't see. Do you know what I mean? Like it's a little bit of a like I said earlier, it just makes a barrier for treatment. It makes a barrier for the person and can kind of make them feel like, okay, maybe I'm not that bad or maybe I'm not that sick, and then it can lead to even more problems and more further spiraling.
Pia, eating disorder treatment is often overlooked cultural considerations. Why do you think the treatment providers are now starting to explore this area?
I think because people with eating disorders from marginalized communities are starting to become more vocal and coming out, even if they don't have the resources. Thanks to the internet, they're supporting each other, and that's getting on the radar. Basically, people are finding each other online, and therefore online, I think they're making more of a statement. Also, I think my fellow activists, we've also tried to raise awareness around it, and other activists as well, around the fact that trying to dismantle the myth that only white, cis, upper middle class women and girls get eating disorders, and trying to also dismantle the myth that there's only anorexia and bulimia. So I think the field is starting to wake up, and that's really, really fantastic. And the work you're doing, Anita's doing, is really the start and the beginning, and we just have a lot more work to be done to raise awareness around the issues.
What about some of the other folks on the panel? What are some ways in which you think that that culture can impact treatment for either somebody from a marginalized community or just somebody who's not in the dominant culture?
I mean, I've heard of a friend who stated that a dietitian told them that Mexican food was too unhealthy and had a lot of fat. And I mean, if you take someone's food, you take someone's culture, right? And obviously this person was very ignorant about the variety of Mexican food that there is. So I mean, there's moments like that. I recall when I went with a clinician, and I mean, to me, it just sounds absurd that oppression is not even included with one's experience and one's experience with themselves and how they view the world, how they view their bodies. And I brought that up with a therapist, and she was very condescending and not understanding where I was coming from in regards to my story. And I mean, that was very dismissive, and that did build a gap between us, because if you don't know where I'm coming from, if you don't know my culture, then you can't really get to me. You can't really help me. That's
What about anyone else? Like, why should we as treatment professionals sort of be thinking about the relevance of cultural issues in treatment for eating disorders?
Oh, I think Dagan is speaking. There you go.
Sorry, I just realized I was on mute. I want to piggyback a little bit off of what Pia was saying, and that's why people are now finally like tuning into this. I think the internet has a huge part to do with this. I also think better healthcare. Obamacare has given way more people insurance, and when eating disorder facilities usually don't take public insurance, having access to private insurance has allowed more marginalized groups to finally access professional care. And so I think clinicians are seeing a more diverse group of clients and patients coming in for treatment, and are now becoming more aware of these issues. And yes, advocacy groups like ours have all really pushed the issue in some really visible ways. And I think we've kind of forced people to pay attention. In terms of kind of like what impact not being culturally competent, not having done one's homework, the impact that it can have on someone seeking treatment. When I was starting the research that contributed to TFED, and kind of my understanding of a need for something that provided services on the ground rather than just like another academic thing, I called around to a bunch of treatment facilities, seeing if they would take trans people. And I heard the most ignorant, really sad questions. I was calling on behalf of a trans woman, a hypothetical trans woman, because trans women, trans feminine folks experience far more discrimination than trans masculine folks who often fly under the radar. And we are also conflated with one another as well. And I heard things like, well, of course, she has an eating disorder. She's a woman now. Her female brain is battling her male brain. I mean, just these, what's her sexual orientation? Because, you know, clearly she would be a sexual predator and couldn't be housed with other people. It was just, it went on and on. And that was a couple years ago, and I am hoping that things have gotten better, but I could not possibly think the horrible impact that these ignorant folks would have on this potential woman's recovery. Yeah, people need to do better. People need to do their homework. Going into this field, it's a social justice issue, and the sooner that we start spreading the word that eating disorders are social justice issues and therefore require an intersectional social justice approach to treat them, then maybe people will start paying more attention to what they need to do to be more effective treatment providers.
So I guess then we're left with the question of, so, you know, what are these issues, and then basically, like, what do we do? What can any of us, or what can all of us sort of do collectively to change some of this? So on more of an individual level, how do we start to create change? So maybe Lakeisha and Gloria, in thinking of cultural considerations that could impact on treatment, what sort of factors should a clinician consider and be thinking about and be curious about?
Well, where are they providing the services, right? A lot of professional treatment services are provided in nice areas. You know, something that's very different to, let's say, a person of color who lives in a low-income area. How can a person from a low-income area go all the way to that area to get treatment? And how are they marketing their services? A lot of times you only see that a lot of eating disorder treatment facilities are only portraying white people as their models for their marketing, or, you know, they have Buddhist or Native American New Age inspired marketing materials, and for a person of color to see that, I mean, and see that this whole facility are all white providers is very uncomfortable because they don't understand the cultural meaning of those things. They don't know what they're doing, and I mean that's a clear sign of not being welcome and not being understood as a person or as a community. So definitely staying away from culturally appropriating other people's cultures. Also, who is part of the team? Are there people of color on board? Are there LGBTQ folks on board? Are there people of all sizes and abilities on the team? Right? Because for me, what's important is it is not so much for a person to be culturally sensitive, but for me to be able to go to a place and have the provider mirror me, someone who has a similar background, who kind of looks the same, right? Also, do they have multilingual materials and services, right? Do they have it in Spanish? Do they have them in, any other languages? Do they accept public insurance? And are they aware of things such as historical trauma? Are they aware of racism? Because these are huge things that have kind of shaped up the way we see ourselves. And if they don't understand that, then there's a huge disconnect. So those are things I would highly suggest providers to consider to make their services more friendly for all people.
Yeah, I guess
I agree with you. I kind of want to piggyback on what she said. It's more not so much also being about culturally sensitive, but also being culturally diverse and be more inclusive, I guess you could say. And obviously access to care is definitely a big one because there's a lot of low-income areas, particularly where I'm at, and also insurance as well. And the nearest eating disorder center near me is like in San Diego. And not everybody has a car, not everybody has transportation, not everybody has the money, not everybody has the time, and maybe tailoring, one of the ways that can be helpful is to tailor the treatment specifically to who you're serving in a way that's not making a blanket statement on everyone. And taking into, obviously what Gloria had already said, taking into account, gender, taking into account, class, taking into account trauma and background, language, and taking into account, not everyone has the same religious views, or the culture that the person came from. And, mainly for me, it's access to care and more, I would say culture sensitive treatment, but more do your homework kind of thing. Like, don't enforce any kind of stigma, advertently or inadvertently, through the actions and behaviors and the way you talk to someone, and the way, who is working there, who's doing the things that are helping you, and things like that.
Lakeisha, you brought up a really important idea of how do we tailor treatment. So there's the bigger idea of being more welcoming and sort of being us as providers being more diverse, which I think is incredibly important. And it's got to be more than just throwing up a stock photo of like one of each of everything, right, on that picture as a way of saying, hey, we welcome everybody. But that's not exactly the same thing. But I'm curious for anyone else on the panel, what would it look like to have treatment tailored towards either specific communities or have treatment tailored towards specific marginalized groups?
I would say, like, be curious without being invasive. Really do your homework. Don't make assumptions. Be sure that intake forms have some fill-ins rather than boxes, especially for race, ethnicity, nationality, documentation status, gender identity, maybe gender expression, and listen to the arc of someone's narrative. like when working with trans and gender diverse populations, what terms do they use to gender their past self, and what is the meaning of that those terms to them? What is the role of food or specific foods in someone's family, in someone's culture? Being aware of historical and current pathologizations that marginalized populations have experienced, and how that can lead folks to be wary of therapists and of treatment. Accessibility, like other folks were saying, is so crucial. Maybe offering childcare if possible, materials in different languages, help with transportation. Like if you run a group, even arranging carpools, and yeah, websites and social media content that actually reflect that EDs are an intersectional struggle, and having a commitment to real diversity in staff and leadership, not just trying to be inclusive among your client or patient population. Having gender-neutral bathrooms, and incorporating traditional foods into meal plans.
I'd like to piggyback on that, which is, immigration status says a lot, and also economic status. And so, if, like Gloria said, if there's a meeting far away or in a well-to-do neighborhood, most likely that's going to be intimidating, and people won't go. And I really want to emphasize that commitment is key. This isn't about taking a course to get extra credit for towards your credential on how to be culturally competent. This is about exactly what Reasons has done and NEED has done, which is looking at your budget and saying, okay, we are going to commit this amount of money, and from that amount, it could be provide peer training or training in communities, not training in communities, support groups in communities, a lot of other healthcare issues when they try to address an issue they do in churches. Go out and find out where are people meeting when they have other issues, where are people congregating. I'm less likely to go to a hospital if they're going to ask for my ID, if I'm a undocumented immigrant, if I need that care. So, and they need to be free. They need to be free. So, if an eating disorder center could allocate some money to do some of this training and care and provide it for communities, just part of their budget, that's real commitment. It's not just, oh, if we come across maybe a patient, it's really about how can we make sure that everybody who deserves this care gets it. Also, I think that the eating disorder community needs to look at this as a public health issue, and the California Endowment has a wonderful initiative of treating communities where they are, and I think that the eating disorder community needs to start partnering with foundations and public health organizations, clinics, to really provide this care and do cross-education and pollination. Because, like I said, you have to meet people where they are, and they're not going to come to a place that's foreign when they have a disease that is foreign to them, or they have a condition. So I think that's really, really important.
And I think that we really need to, move past the cultural sensitivity. I mean, enough time has passed, and I really feel we need to change from the bottom up the way professional treatment has looked like for the past 20, 30 years. It really needs to change. And a more culturally more culturally centered treatment model would incorporate and would include the people in the community who are already doing the work, because we're out there and we're doing this work. And I think that we could, a eating disorder treatment facility that's more established versus something in the community could definitely collaborate in reaching out to these to different people who need the support. Right, we're already doing the work. We just need a little of more support in order to meet people where they're already at. And I think that's super important to not miss that component of the community, because, like I said, these treatment centers are in other areas of the community, far away from the people that really need the help, but they just haven't had the opportunity to voice their concerns and their struggles. So utilize us. Like I said, in TFED, MPP, and amongst other organizations, we're trying to really reach out to people. And I've had people messaging me who are also brown, who are also young, said, I didn't even think I had an eating disorder until I read this or you posted this. I mean, it's just very unfortunate that in many of our communities, we don't even have the language to talk about it. Like, there's no language that we could really talk about our dysfunctional relationship with food or our bodies. So there's a lot of work that needs to get done, but it needs to get done by people from the community, right? And yeah, not miss that community component.
Mm.
Yeah, and that might be a practitioner from clinics going into community-based organizations and doing trainings. So educating other health advocates that are from the community on what to look out for an eating disorder, versus us coming and educating the other way around as well.
I think.
Okay.
Go ahead.
No, you go. You go.
I was just going to bring up a good model would be the Promotora model, which is focused on the brown community, which is pretty much the recruitment of people from that community who have the shared experience, going inside their own communities and being health navigators, right? They have that cultural intimacy connection that maybe an outsider cannot offer in that given neighborhood. So I think that would be a great model to have, where we have, again, people of color, working within their communities.
I wanted to add, when having staff that mirrors a client and patient population isn't totally possible in every circumstance, there needs to be a process, and because not everyone can model everyone, or one person can't model everyone, there needs to be a process of accountability in treatment facilities, on staff for therapists. We're not going to get allyship right all the time, and when we get it wrong, there needs to be a process by which we say, I'm sorry, I messed up, how can I make it better, what did this mean to you, but also let's move on, and like learning from that, and not looking to people who are struggling with severe eating disorders and mental health issues to educate you, and doing that work beforehand, and in other professional circumstances. I think also a focus on less capitalistic, more evidence-based treatment, like FBT, which is very evidence-based and is an easily delivered model that can be very community-focused. We just don't have that. For some reason, facilities are, these boutique vacations in Malibu that offer equine therapy, and that's not necessarily the definition of recovery or what it needs to be, and we could much better use those funds to do something that is community-focused.
Yeah, so more like in the community, and like equine therapy is nice and everything, but there's equine therapy and there's building an eating disorder center in Compton. I'm just saying, there's a way to allocate funds and allocate priorities.
Yeah, on a very sort of selfish level for me, as a provider, when I think about these issues, and when I hear all of you talking, where I immediately go then is to, okay, so like what should we be doing? What are some of these, other than sort of many of the larger issues that we're all talking about, sort of on more of a smaller level. I'm wondering if any of you can speak to like what are some examples of specific cultural considerations or specific issues that either are different for people from a marginalized community, or different, or from a different culture or something, that come up in eating disorder treatment?
I'll give you an example of something that's come up. There have been a couple eating disorder treatment centers or support system groups online and in person that directly use a lot of Native American imagery in their marketing. And I've spoken to them, we've spoken to them about it, and we've gotten pushback. Just no interest in changing that. And so it's more of, well, we spent so much money to put that together, and it's, you know, it's like Dagan said, it's an economic issue, it's a capitalist issue of, well, that gets the people who are, you know, going, this is the hip imagery right now of the music festival in the desert, and that's going to get the music festival in the desert people, you know, but it's not, even though we have spoken to folks in a very thoughtful way, we've gotten pushback of like, well, you know, sorry that hurts you, but it's not looked at as how are we othering other people, and how, you know, so it's really looking at these major microaggressions and not caring, really not caring. And, you know, I think that's what's so frustrating for us doing this work, because we're here trying to create more inclusivity, and some of the conversations we've had have just been completely rebuffed. And so that's why I really, really want to emphasize commitment, because nothing can happen without commitment.
Another thing that I have experienced is that we might not necessarily in the professional field, our work is considered valuable, or it's not accepted in larger conferences or larger, more medically based events. And I think that's honestly, and the reason why we're doing it is because our need is not to begin with. So we're experts. Our lives, our experiences, and they're not, you know, accepted in these. So again, gives that big professional, more, you know, have people judging on. And I mean, if you don't hear from us, and how are these professionals going to improve their services? It's obviously a big lack.
For me, I think personally some of the things I've run into, you know, are the typical stereotypes of the Black woman, and, you know, this doesn't happen because of the beauty ideals in the African American community, and so on and so forth. And, you know, I honestly, it makes it very difficult, not only for me, but for other Black women that I know who have eating disorders. It just, I think there needs to be that, like, chucking that stereotype out the door. Like, we're just like, it's not central to a specific type of person. And but definitely the stereotypes that come along with, you know, being Black and mental health, because another thing is, in the Black community, you know, mental health is still kind of a one of those taboo kind of subjects, and particularly eating disorders, because, you know, when you typically think of that, there's a specific image that comes to your mind. So, you know, when someone comes into a treatment center, like, hey, I'm Black and I have an eating disorder, what are you going to do about that? And it's kind of, you know, like, oh, culture shock, or whoa, something's different than what I'm usually saying, and then you don't know how to deal with that.
Yeah, Dagan, let's put ourselves, for example, into the shoes of a clinician, because you were addressing this issue a little bit in your answer a few minutes ago. Putting ourselves in the shoes of a clinician working with someone from a community or culture with which they're not familiar, what are some steps that the clinician can take to improve the efficacy of their treatment approach, or the applicability of their treatment approach, taking into account what everyone else has kind of already been talking about?
I think everyone really covered it. I'm sorry. And I already said everything I'd written down. So Gloria has written a lot on this subject, and I highly recommend that folks check out her work. TFED also has some really good resources, both trainings and a lot of resources on our site. I wrote an article recently called 20 Ways to Uplift Marginalized Communities and Foster Allyship and Recovery. I think that's a decent starting point. But yeah, I think that folks have covered a lot.
And I think actually what I'd like to ask you, Norman, is what have you been doing? Because you are leading the efforts in this field. Maybe talk about that, because I think that's a great starting point that other people can use.
Sure. Gosh, putting me on the spot. You know, we've been, I think, with this partnership with NITA, this whole campaign of the Marginalized Voices campaign, you know, it's something that's been really important to us as the leadership of this program, and something we've been talking with NITA about for a long time. It's interesting. It's an issue that I think, I would say, even like 3 or 4 years ago, there was very little discussion about issues of culture, and because it's uncomfortable, right? If you're thinking really from the standpoint of a professional, like, it's a really uncomfortable conversation to have when, you know, when the field, when the realm of providers isn't particularly diverse. It's an uncomfortable conversation. It's, you know, it forces all of us to look internally at our own prejudices, which all of us have, by the way, our own sort of misconceptions about things. It's recognizing really sort of our own humanity, and like what sort of needing to think about all the things that we don't know, all of which are really uncomfortable things to talk about. So it's on the one hand really good that there's more conversation, but I'm sure everyone on this panel would agree there's probably not enough still. So I think this campaign has been a really important campaign for us. Obviously, doing as much education as possible within the realm of providers, sort of speaking from the inside, has been really important. We certainly made a commitment to diversity in our staff. This is something you know, Dagan and I have talked about since our first conversation. But we've, you know, as a program, we've been really dedicated to making sure that we have staff who are representative of our communities. You know, we're not only in Los Angeles, which is incredibly diverse, but we're east of downtown, which is very different than being by the beach or something. And I think the fact that our hospital serves a community that's not particularly wealthy, and hopefully that we are reflective of the community that we're in, but also reflective in our particular staff, and it's something we're very proud of, but also still continuing to do a lot of work in trying to make sure we reflect the community. We're very fortunate in that we can serve most people. We can work with men. We can work with trans folks, as well as people from other groups, and it's also something we've been very committed to. But again, even from our standpoint, it always feels like it's not enough. There's always more we can do, and more people to partner with, and sort of try to get the word out in a larger way. And honestly, it's things like this, having these conversations with people like you, because we do need to be educated. It doesn't matter. The fact that I'm a person of color doesn't necessarily make me an automatic insider, right? I can speak to it from a certain perspective, but that's just my perspective. But the more noise we can make, I think the better. That's sort of the heart of an activist, right? Is you want to sort of bang that drum a little bit louder, because it always needs to be louder. You know, we are talking about sort of larger issues. One of the biggest, you know, anytime we do talk about access to services for any people, which has been sort of the largest systemic barrier for healthcare, and then additionally for mental health care, because you not only have, you know, if we start with an eating disorder, there's the stigma of an eating disorder in the first place. There's the larger stigma of having a mental illness in the second place. In many communities, having any kind of mental illness is additionally stigmatized. There's the stigma of belonging to a marginalized community in the fourth or fifth place. You know, there are all of those levels of barriers, and in medical care, there's been this issue of poor people, for example, and people who don't have access to insurance and all the things that we've been talking about, presenting to emergency rooms. And that's very costly. And I think the medical community's been doing much better with providing services in communities, all the things we're talking about. In mental health, it's the issue of people in many communities presenting not to mental health settings, but presenting to medical settings, because that's what they have available to them. You know, you have somebody with an eating disorder who doesn't look like somebody who ought to have an eating disorder presenting to, you know, a primary care clinic with people who aren't even trained in psychological issues, and hopefully they get recognized as having an eating disorder and get sent to, you know, more appropriate treatment. You know, with all of these significant systemic barriers, you know, maybe Gloria, you can talk about sort of with greater understanding on all the levels that we've been talking about. But in order to make a more significant impact, we do have to look at system-level changes. What would a comprehensive or culturally competent, culturally inclusive treatment model look like? I think we may have lost some people, but you know, what about anyone on the panel? What would that kind of treatment model look like in an ideal world?
Provider that does more listening. It's just as simple as that. Really.
Yeah.
It's very to get heard instead of, you know, a provider putting their personal insight, not their medical insight. Any person should be a good listener.
I think I would add it would emphasize being community-based, and also partnerships with community-based organizations. So I don't think it could be effective if it's just done within a vacuum.
And also including preventive services in low income is important, because it's not just about treating, you know, the eating disorder has happened, but helping prevent it. I mean, working with young people, it's very scary to hear these very young girls talk about, you know, them on a diet, them being fat, binge eating, not eating enough. So, I mean, our lives as people of color are significant, valuable, and I feel that it's important to do that preventative work, because if we could prevent it, I mean, that's key. That's important, and alongside create systemic change. We can no longer sugarcoat these things. Can't. We're past that. We're already seeing the consequences that we have, you know, in our own communities. So people really need to start doing their homework, takes, and listening. That's all. Just shut up and listen. Really, that's all it is.
Gloria, sorry, I think that was a little garbled. I didn't catch any of what you just last said.
Neither.
And I know it's important.
I think I forgot it already.
You weren't listening to yourself.
You know, doing preventative work, you know, especially, you know, in young people, having, you know, where young people, it's very scary to see so young and other youth of color talk about how suspect their body or eating underneath. Currently, I have cases of 8-year-olds who had eating, and the parents don't understand it and don't have to treat, you know, and you know how to handle this either, to be honest. But yeah, our lives are sacred, are valuable in this society, and we deserve that of, you know, not privilege, but the access to preventative services as well as treatment.
Mm.
Gloria, in the past, I know I've also heard you. Oh, sorry. I know I've heard you talk a lot about harm reduction. I'm wondering if you might be able to talk a little bit more about that.
Yeah, I think not everybody, many times we're getting treatment. It's like, we're gonna say we gotta, you know, heal right now, you gotta get treatment. And many times throughout my course of me having an eating disorder, I was ready and I didn't want to get recovered. You know, I wasn't ready to get that full recovery treatment. But I think it's important to talk about it. Not everyone has access to valuable, good quality services when it comes to the treatment. So we can meet people where they're at and talk about risk reduction, harm reduction, where people don't cause, you know, damage to their bodies because of an eating disorder. And this is something that's done in, you know, in active user communities, and I don't see we can't do this for eating disorders. And considering the dental issues that happens with bulimia, something I'm really struggling with, right? And there's things people can do in order to help prevent the damage to their bodies. Meanwhile, we're here so they're ready, but, you know, offer the risk reduction in the meantime. It's life, literally.
Yeah, you know, both of those issues of harm reduction and prevention are terribly important, and things that we in the, you know, we on the provider side have really been struggling with on a broader scale. You know, wouldn't it be great if we put our efforts, if we didn't have to do treatment, and if we could put all of our efforts into prevention efforts and prevention initiatives? That would be such a better, more hopeful way to spend our energy. So I think those are both really important issues. So, you know, it is clear that there's a need for a more representative treatment model. I think all of you have given us really really vital and necessary things to be thinking about and to be implementing. I'm wondering if any of you can talk about what steps that either activists or treatment providers can take to begin to move all of us towards real change in treatment for eating disorders.
Definitely start in the community and start with education. You know, go to the places where schools, inner city schools, community centers. I mean, start early sometimes actually, because like people know, like, hey, you know, along with preventative, you know, preventive care, preventive services. I mean, just get out there and just educate and, you know, prevent, like, you know, get the word out. Like, hey, if this is what you're feeling, here we go. Let's do this. Let's find the ways to band together. find commonality, band together, and just start making.
I think one of the things that we've started to do is have treatment providers reach out to activists and educators to do workshops in their centers or at conferences. I think the other step is to look at other initiatives that are going on and partner, as I mentioned before. But even within, if someone is in their own clinic, in their own world, I'm sure they're part of a bunch of eating disorder groups online, and perhaps join ones that they might not consider joining, and just listening, just becoming aware of issues that affect marginalized folks and how they're different, and not contribute necessarily, but learn from other people that are talking about it out there, because there are the groups. And start talking to administrators about ways that you can prioritize some of these sharing of education and knowledge. And to start initiatives like this one. That's what I would say.
I think excuse me, a big step that folks can take is demanding the repeal of the IMD exclusion. The IMD exclusion is the current law that says that residential treatment programs over 16 beds cannot accept public insurance, which is the reason why many don't. Not because they don't want to, but because legally they cannot. And I know there has been some traction with the Anna Weston Act being incorporated into greater mental health reform regarding the IMD exclusion. But yeah, if more people know what it is and are talking about it and are advocating for its repeal, that will give way more folks access to care. Another thing is funding priorities and the reallocation of funds. We need to have higher standards for what we see as legitimate research. I think our funding priorities are, neuroimaging and really brain-based stuff, and that's super important. But we also need to be, allocating funds for research in marginalized communities, and we need to hold researchers and the research they create to a much higher standard. My TFED colleague Jaden had a great quote from the AED conference, and he said, "If your research isn't representative, it's not valid." And I think a really simple step that conferences, for example, can take, if you have poster sessions, if the research being submitted does not have a representative sample and says 90% of the respondents were white, don't accept it. Just don't. That's not real research. That's not representative research. That is not valid. And just simply holding folks to greater standards of care, and maybe the next year you'll only have 2 posters. Oh well, people will get the idea. I think having accessible conferences near public transportation, offering sliding scale or free community FBT trainings, that is family-based treatment, in multiple languages, and incorporating chosen family into that is huge. I think this focus on inclusion is kind of along the same lines as culturally sensitive, and it just really reinforces the status quo and the dominant narrative of these are white treatment providers who need to educate themselves as to how to provide treatment for POC communities, and that needs to change. So hiring more diverse staff or providing scholarships so people from marginalized communities can get the training to work in this field, I think is huge. And also donating to, supporting, uplifting the work that folks like us are doing. And huge kudos to Reasons for having done that.
All right, I think that brings us to the end of the Hangout, and I want to thank everyone for being here. This was just really amazingly insightful, and just like I said before, such a necessary conversation to be having, for us all to be having. And I think we need to just keep using our voices and speaking out, and making that noise. To everyone else who is watching this, this hangout. Thank you for your interest, and thank you for watching. And if you want to learn more about the Marginalized Voices project, please click on the link in the video's description. And thank you all again.